So my second talk relates to personalized risk screening for patients with BRCA germline mutations, but also other hereditary breast cancer genes. As we all know, with the advent of having next-generation gene sequencing available, genetic testing for germline mutations that relate to breast cancer has increased significantly. Now we have panels available that test for multiple genes beyond BRCA1 and 2. That includes PALP2, ATM, CHEK2, CDH1, P53, amongst others. Obviously, because now we test for these genes, we also receive positive test results. The question is, what do we do with these results? And the way we can approach it is that I do in my practice is have an algorithm that relates to patients who already have a diagnosis with breast cancer and to individuals who don't have cancer, but screening is indicated. For patients with a personal history of breast cancer, the implications of finding a germline mutation is important. Most of the data we have is related to BRCA1 and 2 because that's one of the oldest genes and we have long-term follow-up. The other genes are newer, so we don't have a lot of information, prospective information on risk interventions. And for the audience who is interested, there are detailed guidelines in the NCCN. Actually, the new version 2 of 2023 came out last week. For BRCA germline mutation carriers who have breast cancer, screening options for breast include, if they do not undergo preventive mastectomy, would be to continue mammographic screening with breast MRIs. That can be done together annually, or you can alternate every 6 months in a staggered way. For other mutation carriers, such as PALP2, P53, ATM mutations, again, we would recommend to continue with mammographic screening and consider adding breast MRIs at age 30 or after 40, depending on the gene. And again, the details of that is in my talk, as well as the NCCN guidelines. That's for affected individuals. For unaffected individuals, breast cancer screening is similar. For BRCA1 and 2, we start breast MRI screening at age 25 and add mammograms at age 30 and do it yearly thereafter until age 75, when I think it becomes a discussion of pros and cons of continuing with the imaging. But I can tell you, I think otherwise healthy women at age 75, many of my patients don't want to stop, but some may want to stop and say, this is enough screening for me. There are other age cutoffs or starting ages for mammograms and MRIs for other genes that are detailed in my talk and NCCN. But I think it's important that these are discussed with the patients upfront so that they know that it's a commitment. The more difficult discussion for genes beyond BRCA1 and 2 is the data and the benefit of doing bilateral preventive mastectomies. We have data for BRCA1 and 2 that show that breast cancer risk can be decreased by more than 95% in these when preventive mastectomies are done. But we really don't have long-term follow-up prospective data for the other genes. And therefore, I think it's a discussion. It's not a strong recommendation, but a personal as well as family history of cancer needs to be taken into account when the patient discusses preventive mastectomies for hereditary breast cancer genes that are not BRCA1 or BRCA2.